Good evening, everyone. Welcome to the Colorectal Cancer Awareness Forum. We're so happy to have you. This is hosted by the MistyBlue Cancer Care Foundation Limited, and I'm your host, Sandra Brown Thomas. We're here together as a united front in the fight against colorectal cancer, embracing the unique journey of each patient. As Helen Keller once said, alone we can do so little, but together we can do so much. May tonight be a source of knowledge, encouragement, and hope. Our theme, United by Unique, emphasizes a people centered approach to cancer care, highlighting the individuality of each patient's journey and how connected we are in unique ways. Throughout this forum, we will hear from esteemed medical professionals, courageous survivors, and advocates committed to raising awareness and improving care. As we begin, I invite the chairman of the MistyBlue Cancer Care Foundation Limited, a Jamaican pioneer with a diverse background in education, criminal justice, mediation, and conflict resolution, whose personal journey with breast cancer inspired her to become a social entrepreneur. Her support means going and beyond to ensure that cancer patients receive holistic and natural treatment options. She works tirelessly to improve cancer care in Jamaica, particularly in Westmoreland, where the MistyBlue Cancer Care Foundation is located. Please join me in welcoming Miss Dorothy Satchel. Hi, Dorothy. I'm so sorry, but you need to unmute.
Oh, thank you. Am I okay now?
Yes, I'm hearing you loud and clear.
All right. So I was saying it is indeed a pleasure for us to be here doing our second podcast as it relates to cancer. Each month we are trying to look at a different type of cancer and to bring awareness to the public about the risk factors and what is it that we can do to take greater responsibility for our health. And for those persons who are here for the very first time and don't have any background knowledge or information about the foundation, what I can say is that MistyBlue Cancer Care Foundation is a registered charitable organization operating out of the parish of Westmoreland in Jamaica, all right? And the foundation, guess what? We are in our 10th year of operation. Our vision is to make cancer care, support, and accessible health care attainable rights to the citizens of Westmoreland.
Yes,
And
I'm hearing you loud and clear.
all right. So I was saying, am I good? Our vision is to make cancer care, support, and accessible health care attainable rights to the citizens of Westmoreland and its environs. We do this by hosting health fairs where we offer diagnostic screening and health education information, signposting for relevant support agencies, and fundraising events to support the provision of well-needed cancer-specific medical equipment. The foundation operates on a fully voluntary basis and therefore always welcoming sponsorship to make our work more effective. Over the last 10 years, we have been operating in the parish. We have hosted health fairs in communities offering diagnostic screening for breast, prostate, and cervical cancer. We have been able to maintain that because of the support of agencies like the Westmoreland Health Department, RADA, Quartz Optical, AIDS Support for Life, and Red Cross of Westmoreland, to name a few. And through these health fairs, we have seen many community members diagnosed with cancer and supported them through their cancer journey. We appreciate and rely on these agencies for their continued support. MistyBlue Cancer Care Foundation is poised to widen the scope of our reach in the community. We will commence screening for colorectal cancer via our health fairs starting in April in my home community of Darliston. Colorectal cancer accounts for a significant amount of cancer-related deaths in our country and our parish. We invite corporate Jamaica and local agencies to support us in this drive as we live, as well as we seek to save lives and also ours, right? And our tagline is, "Together we achieve more." And let us do this together. Thank you all for joining us on our platform, and we anticipate your active participation. God bless you. Thank you.
Thank you very much, Chairman. Those were very powerful words from you. And we would also invite, I know she said a mouthful, so we would also invite our listeners, persons tuning into our YouTube channel, to stay subscribed. We're on Instagram and so on, so that you can get the latest updates about those health fairs and other bits of information as MistyBlue Cancer Care Foundation Limited plans its activities for its 10th anniversary. It is through leadership and commitment that we drive real change in healthcare. And no doubt about it, Dorothy Satchwell is committed to this task, having done it for 10 years on. Okay, and now we move to our first speaker for the evening, who is Dr. Lincoln Cox, Head of Surgery at the Savannah Lamar Public General Hospital. Dr. Cox brings a wealth of experience in surgical oncology and is dedicated to improving colorectal cancer outcomes. He will be sharing insights on the current state of colorectal cancer in Jamaica. Please welcome Dr. Lincoln Cox.
Good evening, everybody hearing? Okay, well, I'd like to thank the MistyBlue Cancer Care Foundation for again their continuing medical education to the public and various types of cancers. We have done pretty much a significant series during the year. We have gone through breast, prostate, and now we're on to colon. This presentation is a very short synopsis of information and knowledge about colorectal cancer, because this entity or this disease has significant burden on the Jamaican and international public. And we wish to highlight some of the salient points regarding colorectal cancer, being Colorectal Cancer Month. We're going to be looking at what is an introduction to colorectal cancer, what is colorectal cancer, international and local burden of the disease, what are some of the risk factors associated with colorectal cancer, some of the symptomatology, screening and diagnosis, treatment, looking at family and rehabilitation. So what's the colon then? Colon is basically the large intestine. It's the large stripe as seen here on your right. Pretty much in the body, this is how it looks. You have a cecum, your appendix hangs off the cecum. There's an ascending colon, transverse colon, you're descending on sigmoid, and then this little area here is the rectum. Later on, we're gonna be talking a little bit more about the rectum because its treatment is a little bit different from the rest of the colon. This is not to scare anybody, but what's colorectal cancer? This has been around since the ages, and even in the Egyptian mummies that they dug up in the Ptolemaic period, just in the common era, they have found colon cancer within these preserved bodies. So what is it? Basically, colon cancer is an abnormality of growth of the lining or the epithelium of the colon or rectum. It usually begins as a polyp that progresses from hyperplasia, metaplasia, dysplasia into the adenocarcinoma. It's really called the adenocarcinoma sequence. Now, one of the important things about colon cancer, the fact that it progresses through an accumulation of defects, is that we can catch this thing from before it becomes an invasive tumor. And this polyp, as we'll discuss later on, is how we are going to prevent a lot of what we have now, a lot of the deaths from colon cancer. This is a complicated slide, but it is just really looking at the distribution of some of from the red areas, some of the areas with the highest incidence of colon cancer in the world. And if we look at Asia, some areas of South America, and even in North America, we have high incidences of colon cancer all the way up here into Greenland. Jamaican statistic, significant burden. Large bowel or the colon here, significant burden in terms of its incidence. The third leading cause of cancer in females. And if you look on male and female combined together, it is the third leading cause of cancer in Jamaica after prostate cancer in the male and breast cancer in the female. Another diagram looking at the worldwide distribution. So if we just tend to look at areas where breast cancer, where colon cancer, colorectal cancer is lowest in incidence, and in some areas of Africa, lower incidences, and we will come to look at that later on when we talk about what are some of the causes and how does nutrition and your food help to decrease or increase your risk of colon cancer. Now, what are some of the risk factors for colon cancer? Why is it that the lining of the colon starts to behave badly? Well, there are two types of risk factors. There are risk factors that we call it. These are the modifiable risk factors. These are risk factors that we can change on our own. Risk factors such as smoking, alcohol, so the common things that we hear from most malignancies or cancers. Lack of exercise, obesity, all of these increases your risk of colon cancer, colorectal cancer. But then we're left with some non-modifiable ones. Things that we cannot change. We're not able to turn these around because we're either born with them or this is what life brings upon us, like age, a family history of colorectal cancer, certain syndromes within families. Familial Lynch syndrome, for example, was first found in Jamaica in Westmoreland, where families are associated with this type of familial syndrome. And then we have familial adenomatous polyposis syndrome, where the colon is just plated with a number of polyps. And of course, you're at increased risk if you have any one of the many inflammatory bowel diseases, like ulcerative colitis or Crohn's disease. And then there are racial and ethnic predispositions. The American Indians, for example, Ashkenazi Jews, they are at higher risk of getting colorectal cancer. And of course, if you do have type 2 diabetes. What happens and how do you know that you may have a problem with the colon? What are some of the symptoms? What's the symptomatology of this thing? Simple. We want to go through many of them because we want people to remember them. But one, your bowel habits change. What does it mean by your bowel habits change? Okay, well, if you used to go out once a day, you used to pass and you find that, oh, 2 days, 3 days is passing and no stool, then something is wrong, as that bowel habit has changed. Or if you have your stool, you've been passing stool once a day, and all of a sudden you're passing 3, 4 times. Caliber has changed 3, 4 times for the day while you may have diarrhea. Also have to think that something else may be wrong with the colon. Cramping in the rectum, pain on passing your stool, bleeding from the rectum. You go to the bathroom and you're there to pass stool, and there's blood in the stool or blood in the or blood in the toilet, and something is wrong. Or if you're having this persistent bloating of the abdomen or abdominal pain. Important to note that the colon or the large bowel it's just the area of the intestine that concentrate, that makes a stool, that takes out most of the fluid out of your feces and create this hard. So if the caliber of that is changing, meaning that you're passing no more liquidy stool or soft or too watery, then something is happening with the change. There's a change in the bowel habit, and it's something that you want to look at. Now, we mentioned also that big risk factors for colon cancer is age. Age is critical because we tend to find colorectal cancer in patients who are greater than 50 years old. And if any one of these symptoms should develop in an older person, then we have to be thinking that it may be colorectal cancer. Now, the hereditary syndromes that we talked about here, anybody with a family history of colorectal cancer, familial Lynch syndrome, FAP, and so on, these hereditary syndromes tend to occur, and the patient now will present at a younger age. For example, FAP commonly occurs in people in their late teens and early 20s. So it's not a disease only of the elderly, or not elderly, but the patient of middle age. It is more now. In Westmoreland, for example, we have seen quite a bit of familial colorectal cancer in patients who are young. We recently did a number of resections at Sablamar Hospital, patients in their 20s. Now, how do you treat or diagnose then colorectal cancer? This is critical and important to know, because while screening is looking at a normal person and trying to pick up the cancer early, U.S. Preventative Task Force suggests that we start screening for colorectal cancer when nothing is wrong with you at age 45. At age what? 45. Now, the gold standard for screening is doing a colonoscopy. A colonoscopy is a video scope, as shown in this diagram. This is the video scope. This black flexible tube that goes from the rectum, from the anus to the rectum, all the way up the sigmoid colon to the descending colon, around the transverse colon, down the descending colon. The cecum takes a look at your ileal orifice and the appendiceal orifice as well. If you look at the tip of the camera as a light, high definition video camera, it's a place for irrigation and an area for instrumentation, just in case we need to do a biopsy. So the gold standard is doing a colonoscopy, which is widely available in Sablamar. You could also do diagnosis like a FIT or fecal occult blood testing. These both are fecal occult blood type testing. This is fecal immunochemical testing and fecal occult blood. Sensitivity associated with these are not so good as in a colonoscopy, but it's a very, very inexpensive way of detecting DNA or hemoglobin within the colon, which would suggest that there's some kind of a bleeding. We also do digital rectal exam, which is a low sensitivity double contrast barium enema, proctosigmoidoscopies, CT scans, or MRIs to make that screening. Now, colonoscopy, which is a gold standard, this is what you're going to be looking at. For example, this video was taken only this morning. We did a colonoscopy. I'm seeing that we have a presentation today, and we're looking at the colon, and here, just about in the descending colon, we came upon this little thing here, which is a polyp. All right, this is a polyp. And we would have taken this polyp off and sent it to the lab for histology. Another look at what when we approach the colon. It's a very good video. We tried to get a better video, but the videographer wasn't that. But this is what we see when we're doing a colon. This is the lining of the colon. The blood vessels there. The mucosa here is flat and normal, right? As opposed to here, when we came upon an abnormality within the lumen of the colon, this is a polyp. Now, when we biopsy this, it could be a hypoplastic polyp, it could be a dysplastic one, or it could be just the start of an invasive adenocarcinoma of the colon. Okay. So when we screen, this is a table looking at the screening modalities, colonoscopy, with a sensitivity rate of greater than 95%, with an interval of doing it every 10 years. Sigmoidoscopy, which is the same, similar to colonoscopy, but doesn't look in the entire colon. It looks as far as the sigmoid colon and up the descending colon, which is part of the colon on the left-hand side. Majority of colorectal cancers are going to occur on the left-hand side. And that's why doing a sigmoidoscopy is important and very sensitive, 95% sensitivity for distal colon. CT colonography, all of these things are available, and fecal occult blood testing, immunochemical testing, and then for molecular detection of DNA aberrations in the hemoglobin, we'll look at these as well. Now, how does the polyp that we saw on colonoscopy will progress? How would it progress into something like a cancer? All of it starts here, the lining, then grows into this finger-like projection. This finger-like projection gets larger, and then there are aberrations now in their mutations within the gene associated with growth, and now it becomes very, very invasive and very unruly. So the tumor does not now respond to the normal growth cycle, and it starts to invade the wall of the colon. In terms of diagnosis, when we see a little polyp like we saw on colonoscopy, we would do pathologists will then look at the specimen that was sent, create a slide like this, very, very complicated looking thing here, but he creates a slide like this and he knows what he's looking at for cells that are invading and cells that are malignant, cells that have ordered and large nuclear cytoplasmic ratios, and they can come up with a diagnosis that is sent to us. Now, as clinicians, we bear the blunt of carrying the message, because we would send the biopsy off, and then we'll get a report from the pathologist, and now we have to deal with the patient. We have to let them down very easily, and sometimes these very harsh diagnoses of colorectal cancer. And then we go about our business of now trying to make them as we try to cure them then. But before we do that, we have to stage the cancer. And we have our ways of staging cancer. And depending on the stage, we can advise the patient as to the likely the likely risk or likely chances of cure. So there are various stages. When we get patients who are stage 1 or 0, or even stage 2, what we call early stage disease, we're happy because we know that overall survival is. However, when we get patients now with stage 3, as this is stage 3 here, this little area is the tumor or the little polyp that would have seen on colonoscopy. And now, if you see stage 3 is now, it has now breached the wall of the colon. So this is the wall of the colon, and this tumor now has breached there. When it reaches the wall of the colon, it starts getting now into lymphatics and the blood vessels, and the microscopic tumor cells start to spread. And stage 3 is late stage disease, overall 5-year survival. Between stage 3 and stage 4, it's usually less than 15%. And this is not a good thing. And this is why screening is so important. So would have not gotten to stage 3 and stage 4. The diagnosis of colorectal cancer is not a doomsday. It's not the end of the world, because there's treatment there for colorectal cancer. That's the good news. So for all patients who may develop the symptoms and were unaware and probably come in late, and we have made a diagnosis of colorectal cancer, then there is treatment. So the mainstay, though, of treatment for colorectal cancer is surgery. Right? General assessment of the patient and decide whether we're going to go in for surgery, or in the case of rectal cancer, whether we are going to give the patient neoadjuvant chemotherapy. So there's surgery, there is the chemotherapy, radiotherapy, and then there's targeted hormonal therapy for colorectal cancer as well. In modern times, we can do minimally invasive colectomies, laparoscopic colectomies. We still do a lot of open procedures because a lot of the procedures we see are sometimes a little bit tricky in advanced cases. And then for the distal rectal cancers, we do what we call an abdominoperineal resection, which unfortunately renders the patient with a stoma bag for the rest of their life. However, I can tell you that most patients, once they have alleviated, they have cured their colorectal cancer, having a bag on the side of the abdomen is never a problem for these patients when they have survived. Because colorectal cancer is a familial disease in 15 to 20% of patients. We know that the family is very important. So when we come across a patient who we have diagnosed with colorectal cancer, then we start looking almost immediately before the personal treatment at the family, rest of the family, and trying to figure out whether this cancer is one that is sporadic or it's associated with some kind of inherited genes or some familial syndrome. Because if that's the case, then we now have to go examine the mother and the father and the sister and the brothers and so on to see if we need to screen them for colorectal cancer. So you are 2 to 4 times more likely to get colorectal cancer with a family history of colorectal cancer. But we don't want to go through this very detailed looking thing here, but just to say that there are patients who are average risk, right? And there are screening guidelines for average risk patients. There are patients with a family history of colorectal cancer, and the screening guidelines are different. And there are those with a hereditary syndrome, genetic syndromes like Lynch syndrome. We keep saying this about Lynch syndrome, and Westmoreland is very, very connected in Westmoreland. And so there are a lot of different age now limits that we're gonna screen these patients for colon cancer. So if we look at FDRs, which are first degree relatives, and then SDRs are second degree relatives, we take all of this into consideration when we are seeing a patient with colorectal cancer, whether or not they, and we use this now to risk stratify the patients in terms of how we're going to treat them. Again, another guideline, we use various guidelines to look at colorectal cancer and to treat patients. And when we're going to start, the age we're going to use to start treating the patients based on their family history. Oh. Okay. So in short, that was a very short presentation on colorectal cancer. Fact that it's the third leading cause of cancer-related deaths in Jamaica. Worldwide, it is the second leading cause of cancer-related deaths and a significant burden to everybody throughout in Jamaica and the wider world. And so it's when you have bloating or a change in bowel habits or abdominal pain, or you tend to have diarrhea, or you're having constipation, or you pass blood from the bottom, it is very, very important that we see a doctor who would make the appropriate referral for screening and for diagnosis of colorectal cancer. Thank you, guys.
We want to say thank you very much to Dr. Cox for that powerful, very informative presentation. I learned so much because I'm used to the term colon cancer, but for me, doing this, joining this group and being a part of it, I am just now becoming familiar with the term colorectal cancer because for me, I only know about colon cancer, right? So I'm sure there are many others like me who would appreciate all of the very wonderful, as I said, extremely informative information that Dr. Cox presented. I've made my notes, right? So that I feel that I'm in a better position to actually to advise persons to tell them about some of the symptoms to look for and the various risk factors. So I really appreciate that. Thank you very much, Dr. Cox. As Nelson Mandela said, education is the most powerful weapon which you can use to change the world. And speaking for myself, and I'm sure for other persons, with the knowledge we've received, we are now more empowered to take action. As we move on to our next guest, we now have the privilege of hearing from a cancer survivor who has walked this journey with strength and resilience. Her story will serve as a source of inspiration and encouragement for all of us. Please welcome Debbie Walters. Hi, Debbie. Is she on?
Hi, good evening. Yes, good evening, everyone. Good evening,
Okay.
Debbie.
Good evening, Debbie, and
Okay.
thank you so much for joining us. We really appreciate your willingness to
You-
share your story because having heard Dr. Cox, some of that information persons might find, oh my God, when you hear persons hear cancer, they immediately start to, all the negative mindsets fill their mind. So it's wonderful to have you on board. And if my first question to
Okay.
you would be, would you tell
Yeah.
us how you found out about your diagnosis? What was the circumstances?
Okay. So, good night, everyone. So I found out I had a lump in my breast, but I wasn't paying attention to it. My husband told me to go and check it out, then my kids, then my niece. I wasn't really checking it out either. At one point, I went to church and a church sister of mine, her sister-in-law, died, and she was telling me, Debbie, go and check it out, go and check it out. So Miss Dorothy has given me one of her thing to go and do the mammogram. So I went and did the mammogram. After I did the mammogram, it has shown that the lump is there. Went and did the ultrasound, it still showed the lump. So went and did the biopsy, and after the biopsy result came back, I found out that I have breast cancer. I was frightened, but was adamant in doing the surgery. I was between opinions, but I, spoke to Dr. Cox, and he encouraged me to went and did the surgery. So I went ahead, did the surgery. Now it was okay. Now I'm home healing, I'm being positive to everyone, because even when persons come to the hospital to look for me, she said, you don't look as if you're someone who have just done surgery on a breast cancer. So I'm telling everyone out there that whenever you are, diagnosed with the big C, you're going to be
Yes,
frightened. But
certainly.
guess what? If you just put the Lord in the midst of everything, he said, fear not, because he's with us. So we need to put him in everything that we do. We need to trust him and have faith, and to know that he came down to die for our sins. So we just need to put that faith and our trust in him, and to know that whatever we need, we just need to ask him for it, and to just go out and to encourage others that there are diseases in our lives, and we haven't call them on ourselves. So we just need to trust God and to know he will heal us, and whatever we do, we just need to put him in the midst of everything. We must not be frightened, you understand? We must just put him in the midst of everything. My encouragement to all the survivors, all the cancer patients out there, they just need to be focused. We are a human being. We're going to be frightened at times, and we're going to be scared, but we just need to focus and to trust the Lord. He's in the midst of everything for us.
Okay, thank you very much, Debbie. I realize that you've put your faith. Your faith has brought you this far, and it will continue to take you the rest of the journey. So just to be clear, you're saying that you
Yes,
just recently had surgery.
yes, about a month ago. I did it
Okay.
about a month ago.
Okay, so you're waiting for the staging now before chemotherapy and the rest of it.
Yes, miss.
Okay. All right. Well, we thank you very much, Debbie, for sharing your story. It will serve as an inspiration, and already I see you're becoming an advocate and helping to spread the message that having
Yes.
cancer is not a death
Death
sentence. You can
sentence.
overcome.
Yes, we just need to trust him, and to, change our diet in the meantime, because,
Yes.
just whatever we eat at times, put us where we are. And I'm telling you, I used to eat a lot of sweet. I didn't even used to look on, the diet. But now I'm telling you, I am focusing on diet and trusting the Lord, and I know he's going to heal me. So to
Amen.
all the cancer people out there, I'm just telling you to hold on to the hands of the Lord. He is bigger than all of our problems.
Yes. Okay. Thank you very much,
Thank
Debbie.
you.
What an inspiring testimony. We just thank you
Thank you
very much
guys for
for
having
sharing
me on.
your
Okay.
journey.
Okay. Have a
Thank you
wonderful
very
night.
much.
You're
And
welcome.
to
figure out whether this
this reminds
category is
me
that sporadic.
of the words of Maya Angelou.
So inherit.
I can be changed by what happens to me, but I refuse to be reduced by it. And having just heard from Debbie, Debbie is a true example of that. Okay, right now as we move on, our next guest will be Dr. Jean Powell, a distinguished retired doctor of nursing practice. Her expertise spans critical care, emergency medicine, epidemiology, and infection prevention, with a strong focus on supporting patients before and after surgery, including those undergoing chemotherapy and radiation. Dr. Powell, with her extensive experience in patient care, will guide us through crucial measures before and after a colorectal cancer diagnosis. Let us welcome Dr. Jean Powell. Oh,
Hi,
Dr. Jean. Yeah, okay.
good night,
Okay, Dr.
everyone.
Jean, over to you. Good night.
Well, Dr. Cox laid it out there for us. It was a lot to absorb in a short space of time. However, he touched on a few critical and salient points that we all should focus on. But I'm going to take it to the next level, and I'm going to ask the question, where do we go from here as patients, as family members, as advocates? What happens before you get the diagnosis of any kind of cancer? And since we're on colorectal, I will just stick to colorectal. How do you feel as a person, and how do you feel after? So you've had your diagnosis, you've gone through, you've done your your colonoscopy, you've seen your doctor, and he says, well, you have to go and have surgery. What does that surgery entail? How do you make that decision to go forward? Who are your support system? Where are they coming from? And then we look at cost here in Jamaica, because we have to be realistic about the cost of care and treatment here in Jamaica. Your treatment basically will depend upon the type of stage, the type and the stage of your colorectal cancer. Your options will also depend on the results of the tests of the cancer. Your health and your personal preferences also plays a significant role. Surgery is used to treat most, if not all, colorectal cancers. Surgery involves removing part of the small intestine, depends on where the cancer is located, or the large intestine, depends on where the cancer is located. Some persons post-surgery will either need a colostomy, which is a pouch on the outside where fecal matter will get into, or they will need an ileostomy. So it depends on if it's a large bowel or the small bowel, or the small intestine is affected. Where there's an opening which is created in the abdomen or we say in the belly, to allow stool to pass out of the body. Some people may need these ostomies for several months, which is temporary. Some may need it for longer period, depends on how well their healing and how much of the cancer was taken out. So now we get to, what do we do when we have this going on? And then we talk about radiation treatment, medicines such as chemotherapy, targeted drug therapies that patients have to go through, or immunotherapy. In many cases, more than one type of treatment may be needed, depending on the type of cancer. The doctor in question will help you decide what treatments are best for you. But you as the patient now has to decide, how am I going to live with this pouch? How am I going to support myself if you will work in person? How am I going to pay the cost of having this surgery, pay the cost of treatment? And then you have to ask the doctor, there's some salient questions that you need to ask. Number one, what is the goal of the treatment that you'll be getting? Then you ask the second question, what type of colorectal cancer do I have? And then you get to, what stage is my cancer? And what does that mean? What can you learn from the test results? Will you need more tests? If you had surgery, can the cancer be removed completely? Will I need an ostomy? How long will I need it for? How will I take care of it? If it's a temporary ostomy, when will it be reversed or removed? And who will reverse it? Do you need genetic testing? Because Dr. Cox talked about here in Westmoreland where there are a lot of genetic cancers, cancer markers that have been detected. So all of these questions are wide open for that patient. Now you talk about side effects. Not everyone will have the same side effects from the treatments, for example, from the chemo or the radiation that they will receive. So you now is left to ask the doctor another set of questions. What are my treatment options? What does he or she think is best for you and why? What side effects you may have or may not have, and what can you do about them? How will you know if the treatment is working that you choose, that you both decide on? Treatment is a combination of patient-doctor decision. It's not a patient alone, it's not a doctor alone that will decide what treatment options. It has to be a mutual understanding between both parties. You have to decide, and the decision has to be made, how often will you get to treatment? How will you get your treatment? How is your transportation going to be paid for? And how long will those treatments last? Can you drive to get your treatment if you are someone that drive? If not, you must think about how you're going to get there. Activities, are you going to be able to do your usual activities? And some things that most people will not ask, will this affect your personal life, your sex life, and for how long? And what can you do to help this? So it's a lot of questions that patients will ask, or they may not ask because they don't realize that they should be asking these questions. How do we go about supporting and providing support for patients post-diagnosis of colorectal cancer? What support systems do we have that is readily available for patients here in Jamaica, in Westmoreland? And how does MistyBlue Foundation help, and how can we continue to help? MistyBlue Foundation, as you know, operate on a volunteer basis, donations, but there's just so much that MistyBlue can do. How can we further expand and help this foundation to help those out there? Because we know that Jamaica, the average cost maybe for a CAT scan could be $40,000, $50,000. And if you can't afford it, you don't get it. Chemotherapy treatment. I know someone right now who has to travel from Westmoreland to Kingston, to UWI, to get chemotherapy. And the cost is astronomical. One dose of the medication that this person is on is $2,500 US. Lucky for this person, he can afford it. And he can afford the treatment, but it's still a burden. Imagine someone who cannot afford it. What are the options? Support systems. Very few of our people here have support system that is intact that can help them through this phase. Do we have support systems that are set up here in Jamaica? Do we have groups? And how can we, as a foundation, develop these groups so that patients can call us and say, I need to speak to someone? How do we work with the Ministry of Health to get these groups started? Is there a hotline? Not sure. So after the diagnosis, after the treatment, if you can afford the treatment, what's next? Self-esteem problems may be there. Like I said, someone has to live with an ostomy bag, whether it's a ileostomy or a colostomy bag, for some period of time before it may or may not be reversed. How do we support these persons? What can we do to help? And how do we reach out to these persons? The long and short of it is we have to spread the word. We have to start talk about healthy living, staying healthy, preventative medicine, preventative measures. And Dorothy mentioned that we'll be kicking off and having some health fairs started in Darlington, working the way through the parish of Westmoreland. We are hoping and praying that we can get enough support that we can do the fecal occult blood testing on site. And then following that, once someone is identified with possibly colorectal cancer or some signs of blood in the stool, we can send this person for a CAT scan. But a colonoscopy, sorry, where is the money coming from for the colonoscopy to be done? Again, we have to reach far and wide to get these colonoscopies done and get them done in a timely manner. Now, patients have to deal with their feelings. It may make them feel scared, they may be sad, they are nervous. It's normal for persons to have these feelings, and there are ways to help you cope. So if you're someone out there who have been diagnosed and you're going through the treatment, or you haven't been diagnosed and you suspect that you have something going on, please do not bottle your feelings up. Try to reach out, speak to someone, talk your feelings out, no matter what they are. It is okay. We have to let patients know or people know that it's okay to feel sad. It's okay to be nervous. It's okay to get your diagnosis, but always remember, having a diagnosis of cancer, of any type of cancer, it's just one of those diseases. If someone say you have high blood pressure, do you sit and worry? No. If they say you have diabetes, do you sit and worry? No. So you're not the disease. The doctor may tell you it's okay to do things you enjoy, like spending time outdoors, going to a movie, going to a sporting event, going out to dinner. It's okay. You live your life. Go out, enjoy yourself, eat healthy, and move on to the next phase of whatever it is that the treatment will ensure, or the diagnosis is there. There's nothing you can do but go along with the treatment plan. Do not bottle your feelings up. Seek help. Seek out MistyBlue Foundation and other foundations that are out there. There are foundations online that you can join. They may not be located here in Jamaica, but they are out there. Thank you.
Thank you very much, Dr. Jean. I learned so much from that. And I'm sure we'll have to find a way to share that information with other persons. So that they can benefit from the valuable information you have shared. The questions were spot on in terms of I mean, as I said, I don't remember them all right now, but I definitely think that we have to put this together because information was so critical to persons who will be facing a diagnosis of colon cancer. Very, very timely information. And your words reinforce that early detection and proper care can make all the difference, as well as having a good support system to take you through this journey. As I'm reminded of the words of Winston Churchill as we come to this point, success is not final, failure is not fatal. It is the courage to continue that counts. And courage is required by persons facing any type of diagnosis of cancer, as well as any other disease that affects them. You must have the courage to continue to take the steps, to seek the support, to ask the questions that will help you on your journey to overcoming this disease. And the presentation by Dr. Jean brings us to the end of the official presentations. And now we're going to open the floor for questions. I have one from a listener who came to us on our YouTube channel. She sent that much earlier during Dr. Cox's presentation. And the question is, let me see if I locate it, from June Whitley. Thank you very much, June, for tuning in to this webinar. And the question is, what is the average cost of a colonoscopy? I don't know if that can, or Dr. Jean can give us that answer off the top of their head.
You don't look as if you're someone.
I think Dr. Cox would more be in tune to tell us what's the cost for
Okay.
a colonoscopy, because that's right in his backyard.
Okay, Dr. Cox, is he on?
Yes, he is.
Okay.
He might be away from the microphone at the moment, but I think the average cost for the colonoscopy is between $80,000 to $90,000.
80 to 90, yeah.
Between $80,000 and $90,000 Jamaican dollars.
Okay, thank you very much for that response. I hope June, you're still tuned in and you are listening. Okay, next question. I believe I got a second question also for Dr.
Oh,
Cox.
I'm sorry, Dr. Cox said he's not, he needs to allow him to speak. Let me
To
allow him to
unmute him.
Yeah. Okay. Try again, Dr. Cox. Now I try to
No,
unmute.
he's still muted.
Oh, no,
Okay.
I'm not changing the device because I'm on my phone because I'm moving.
Okay.
Yeah, you're right. It's about 80, 90, or even $100,000. I think we probably do it the cheapest in Sablamar for probably, I think it's $75,000 in Sab.
Okay, thank you very much for that information. We also have another question which is addressed to Dr. Cox as well. Do you think fear of colonoscopy adds to the problem of the diagnosis of colorectal cancer? That's a question from one of our listeners. Dr. Cox? I'm not sure he's hearing me. Oh, he did say he was moving.
Hold on. I'm just giving permission to unmute.
Yeah. Yeah, I think in general, when it comes on to invasive procedures like colonoscopy, and even to be more gender specific, with males, they tend not to like procedures that proceed through the rectum. It's uncomfortable for them, and they just don't like the whole experience of it. However, when it comes on to colonoscopy, I think it might affect the way we screen. I mean, the gold standard of screening, because some people may not like the procedure, and I think it's just a matter of education in terms of what the intended goal of colonoscopy is. But hard to say whether or not it's affecting the rates at which we do colonoscopy, because we haven't really studied it. But just from a cultural background, from even extrapolating from men who are afraid of doing digital rectal examinations for prostate diseases, that this might be a deterrent to some people taking on colonoscopy for screening.
Okay, thank you very much, Dr. Cox. I see a raised hand from Dorothy.
Yes, and I have a question for Dr. Cox quickly before he goes. Dr. Cox, are you there still?
Yes, still here.
All right, you mentioned something about environmental, because there was one type of cancer that you made reference that it was identified in Westmoreland, yeah? What I want to know is how much does environmental versus socioeconomic conditions contributes to one having high risk factor for colorectal cancer?
Well, we all know from general studies that populations or people from low socioeconomic backgrounds tend to do worse with cancers, and it's for a wide range of reasons, like even from preventative measures and what you eat and what you consume, to screening, the ability to screen and the cost of screening. People from low socioeconomic backgrounds tend to not have they don't have the resources in order to do those early screenings. And unfortunately, those low socioeconomic background also are low in terms of their information and what is it that is happening to them. And so they usually do worse when it comes on to cancers in general. The environment now has a lot to do. We talk a lot about what may be in the environment that may predispose you to colorectal cancer. A lot of it has to do with what you intake, as to what may be even endemic within the soil. We're not sure, but we know that your food, whether you have a culture that embraces smoking and alcohol intake, those modifiable factors are some of the things that increases your risk of getting colorectal cancer and other cancers as well. So yes, your environment does. And when it comes on to Lynch syndrome now and its predilection for Westmoreland, that is a specific type of gene mutation that's occurring, that is passing down through families. And that now is something that you really have no control over, because that mutation started some time ago and it just stay within that family, and it's passed down through the generations. You really can't stop that one.
Okay, thank you very much, Dr. Cox, for that. I see Dorothy has a follow-up question.
Yes, because thank you for that, Dr. Cox. And I don't want to hog the question sessions, but you mentioned the age at which persons should start the screening for the colorectal cancer, and that colonoscopy is recommended like once in every 10 years. But a patient who does the first colonoscopy in 2020, for example, and then 2-3 years later becomes symptomatic, what's the next step after colonoscopy? Since you're saying that we should wait for, is it within a 10-year period? What would be the other thing that you would do in between the colonoscopy and 3 years' time when the patient becomes symptomatic, or there seems to be an advance in terms of what is being manifested?
Well, okay, so when you do a colorectal cancer screening, where you do a colonoscopy, this is in a patient who has no symptoms at all. Because if you're symptomatic then you're not talking about screening anymore. You're talking about looking for a diagnosis for whatever your symptoms are. But if you're going to screen in the general population where you start at age 45, at one point, they had recommended screening starting at 50. However, it's now being reduced through studies to at 45 now. You start at 45. And that's US Preventative Task Force that has recommended 45. Now, if you are an asymptomatic person who did a colonoscopy and the colonoscopy was normal, right? It's not that you can't miss lesions in colonoscopy, because you can. A lot of what you see on colonoscopy depend on the bowel preparation, how difficult the screening, the colonoscopy is, and sometimes anomalies, slight anomalies with the colon that may make it difficult to navigate the colon at the time. But if everything is equal and the colonoscopy is normal, then you wait another 10 years. However, on the onset of any type of symptoms before that 10 years, then you have to go back and do the colonoscopy if it's specific to the colon. You have to go back and take a look, because it doesn't mean that the colonoscopy that was done before was perfect. You could have missed a polyp, and now the patient is now presented with symptoms. So even though it says 10 years, it's only 10 years if 10 years you're symptom free.
Thank you.
Okay, I have another question here, also for Dr. Cox. What role does hormone play in developing colorectal cancer? And it has a second part also as well. Can taking certain medications heighten the risk? So that's really two questions, actually. Dr. Cox?
So when you say hormones, in general, I don't think there's an increased risk factor in taking hormones, because that question in terms of taking hormones, I'm not so sure what.
No, it actually it doesn't say it doesn't say taking hormones. It says what role does hormone play? I guess because maybe the person's relating it to like breast cancer, where you know that sometimes your hormone can play a role in developing it. So I think they're probably asking it in relation to a general question like that.
Oh, hormones? No, not directly for colon cancer, because we know what risk factors are, and hormone doesn't play much of a role in colon cancer.
Right. What about medications? Medications that you may be taking. They're asking if taking certain medications, they didn't name any specific one, but they're just asking if taking certain medications heighten the risk?
Well, we don't know specific medications that may heighten the risk for anything. What we know is that certain medications nowadays even are highly preventative, are thought to be preventative for colon cancer, because now they're thinking that certain NSAIDs are preventative for colon cancer. Even aspirin may be now preventative. It may now prevent colon cancer. We don't know. What we know is that things like nitrates and nitrites, if they are passing through the colon and the transit time is long, then we're thinking that it might predispose you to colon cancer. However, and that's why we talk about the food you eat, because transit time is not long if you're eating if you're having the right fiber, if you have the composition of your diet has significant amount of fiber, because you're going to be passing, your transit time is going to be short, and so your risk of exposure of the colonic lining to various chemicals or even medications would not have been long enough to transform the colon. So no, we're not sure about medications that may be taken, but we know that there are medications that could be preventative.
Okay,
Dr.
thank you very
Cox.
much for that, Dr. Cox.
Can
Dr.
I
Jean,
chime in?
Sure, Dr. Jean, go ahead.
And it goes back to bowel habits, the foods we eat, but some people don't realize that having chronic constipation is a detrimental thing, they have constipation and they think it's nothing. So like you talk about the transient times or the transit time for things to pass through the bowel. If you have certain medication sitting in there that hasn't been processed and it's sitting in there and you take another and things are building up and you go, I have had patients that come in and say, I haven't moved my bowel in 3, 4, or 5 days. And they think it's normal because they've had this going on since they were young. And they always thought this was a normal process, you know? So we have to tell patient that constipation or not moving your bowel for 2 days is not normal, or even in 24 hours, it's not normal if you haven't moved your bowels.
Okay, and I think that's such a common thing. All of this information sharing and so is really pointing to a great need for education because well, I don't recall hearing that before in
Mhm.
that the transit time and all that information and just the importance of passing your bowel because persons take it for granted. Okay, my I am regular every day, but no, I'm not. I'm the other person that is not regular every day. And for us, I mean, just without information, you just take it as maybe that's the way my particular body is because, as you say, sometimes from childhood,
Yeah.
that has been a pattern. So you really don't know. So with information now, you will know that hey, that's not regular, and you probably need to eat more veggies, drink more water, or what steps to take then to correct that situation. Yes, Dorothy, you have another a question or comment.
Sorry, me again. This one is for Dr. Jean. I had a male person I was in dialogue with, and he was at the stage when he was supposed to do the surgery, and or he had done the surgery, but I think the conversation was around him getting the colonoscopy bag. Is that what they call it? The bag?
Mhm.
And
Mhm.
and he was very, very resistant to it. He said, me a big man. And he said, how a big man fi have sex with bag? And he put a little decoration to the bag. You know what kind of bag? He said the S bag, you know? And my concern was the type of conversation that would have gone on with him or with him and his partner. And
Partner.
what is it? Because there's obviously a niche there for that conversation to take place with you, the patient, and with your partner, and sometimes the family, in terms of how do you prepare yourself to carry this extra piece of accessory and the psychological impact it can have on your self-esteem, on you, how you relate sexually and otherwise. How do we then have that conversation? Where does it start and what does it entail?
It has to start at the time of diagnosis, and that it starts between the patient and his doctor at that time. But like I said, some patients will not ask that question. What about, whether it's a male or female, what about my personal life? What about having sex? Most people, that's a taboo. So sometimes you as the practitioner have to initiate that 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 conversation and you take them through the steps, you know. Well, what are your, and then you bring in the partner, whether it's a wife, the girlfriend, whoever it is, maybe. It has to now become a three-way conversation because, like you said, self-esteem is a big part of any. We know that with breasts, a woman loses a breast, with this, you hope that it's reversible because in some cases, it's not reversible for long periods or never. Depends on the stage of the cancer. So that becomes a two-way conversation that segue into a three-way conversation. And like I said, a lot of times the practitioner has to initiate that conversation because the patient will not initiate that conversation.
Okay, thank you, Dr. Jean. You spoke earlier in your presentation about support groups and the role that they can play in all of this in just helping persons to cope. Just by way of information, is there any, and especially since MistyBlue is focused in Westmoreland, is there any support group there that persons can be directed to or anything like that?
Not that I know of, but if there are a couple of groups online that are not necessarily here in Jamaica, they're overseas. And they have one for lymphoma, they have the colorectal groups, they have the breast cancer support groups. So there are support groups out there, but you have to reach out to them. Here
Okay.
in Westmoreland, I'm not aware of any support groups here.
Oh, it seems like that would be an area of need, you know.
It's a big need.
Yes, yes. Okay, that is actually something I have an interest in, but we'll address that later. Any more questions before we wrap up? Let me just check. Any more questions coming up from YouTube? Not hearing. Let me just check if there are any other questions. No, that seems to be it for questions, but I think this evening has been a wealth of information, and we will have to be mindful of that, the ways in which we prepare to share this information, because I think it is too much to just leave in this webinar, that we will have to find ways to disseminate this very important information on colorectal cancer, and just keeping ourselves healthy, preventing it, and if we are diagnosed, treating it, as well as leaving ourselves open to support family members and other persons in our circle who may have come down, who have been affected by this disease. We've heard so much valuable information tonight, and this discussion has been truly enriching. First, especially, I can say that personally for myself, not just from, not just saying it, but it definitely has been enriching. And we want to reflect on the shared wisdom, personal stories, and the knowledge that has equipped us to move forward. And as we close, once again, we invite our chairman, Dorothy Satchwell, to do the acknowledgements and to give us our closing comments. Dorothy?
Thank you, Sandra. Ladies and gentlemen, I don't think we can really appreciate tonight the significant impact of the information that was shared here. We do not have a lot of persons live, but what I can tell persons is that the information is there, available on YouTube for persons who want to go back and look at it. And I think I have said this a lot of time, and I'll always say it, that when it comes on to cancer, whether it's going to be colorectal cancer, breast cancer, prostate cancer, we need to move away from that place where cancer is that thing that we see it affecting other persons and not affecting us. And we need to move away from the place where we're not willing to see cancer as a thing until it gets into our faces, when it becomes our problem or the problem of our loved ones. Sandra spoke about the importance of education and how empowering it is. For the last 10 years, the MistyBlue Cancer Care Foundation has consistently been doing screening for prostate, breast, and cervical cancer and giving information. We are now expanding, as I said in the beginning, to look at colorectal cancer, how we can share that information. In our WhatsApp chat group, we have been putting posts out. We have had little response or engagement from team members to see the effectiveness of it. But we will continue to share, because we know we are from a culture of people who do not really gravitate towards knowledge and information and reading and stuff like that. And in time, we want to go out and be in the community where we can interact on a more one-to-one basis in terms of the sharing of the information. We have a health fair coming up in Darlington on the 27th of April, and that is the first time that we are going to start doing the blood occult, is that the proper pronunciation, for colorectal cancer, to see if we can at least start the process, because indeed, based on what the statistics that Dr. Cox has shown, we know it is a thing. Colorectal cancer is all the way up there, right behind breast and prostate cancer, and the information sharing, the diagnostic screening really has got to get the information out there. So we just want to thank Dr. Cox, thank Dr. Jean, and thank you, Madam Moderator, and for all those persons who have logged in, those who have asked their questions. Let us keep the momentum going and keep sharing the information, because I always believe that it is good enough if we can save one. Yeah. So thank you very much. And remember, each month we'll be looking at a different cancer. Last month we look at cancer prevention. This month we're doing colorectal cancer. Next month we move on to something else. And please stay tuned and engage as we keep sharing the information. All right. And thank you very much. God bless you all. You're
Good
still
night,
muted,
everyone.
Sandra. You're still muted, Sandra.
Thank you very much, Dorothy. And as we close, I would give a final comment using the words of Margaret Mead. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has. And I think just based on the wealth of information shared here, the expertise that is within the group, the response from listeners, from the persons who are on, we just know that we have a mission to carry out, and it is vitally important. Although we are small, we are strong, and we will do what is required to be done to share this information. So we're inviting persons now, stay safe, stay informed, stay united, and have a wonderful rest of the evening. Thank you very much.
And please subscribe into the YouTube channel, all right?
Oh yes, and let me also remind you that we're on Instagram, and please share, please share the information, share the link afterwards. Persons can listen, because I think it was been a wealth of information, and we need to have persons, you inform yourselves so you're able to inform others. That's what we want. Thank you.
Thank you. Okay. So Dwight, it stopped streaming now. Is it still streaming, Dwight, or is that stopped now?
You have to stop it on your end.
Okay. Oh, you mean I mean the Zoom, I'm talking the YouTube one.
Yeah, stop it on your end. Or make me host.
I'll make you host then. You're no host, Dwight.
Okay, thank you.